Morphology in the anterior leg is very, very important because if your patient have any injury history that you think related to the muscle tear, muscle contusion, compartment syndrome, delay of muscle soreness, they are all related to muscle morphology and hypoechoic. Okay? So remember the upper third, two muscles and the two muscles only. In here, it's probably just a little head of the extensor hallucis longus. But some people, the head of the extensor hallucis longus cannot be observed completely at this level. But some people can. Your tibia and tibialis, the head of the extensor hallucis longus can be observed at this level. She is more like a European. Her extensor hallucis longus cannot be observed in this area, but only in this area, middle, a bit low. Yeah, that's different. So the same scale. Okay, I'm not going to read this for you because they are not the details about the scanning the muscle at different levels. This is an example of one windows. Because if you look at the textbook, if you look at textbook, they show you a picture like this. Unless you learn ultrasound for many years. Otherwise, you are not going to understand what the picture means. Okay, so you need to find a textbook, probably not very good, but show you just one pictures, one windows, right? So, in this case, this is the tibia. Tibialis anterior. No borders between the superficial part and the middle, no border between the superficial part and deep part. So, it's upper third or middle. Upper third or middle. Okay, who is the today is the Valentine Day. Really? Okay. So the high school story I said is very good. Right. Okay. The lady who wear yellow mask. The lady who wear the yellow mask. Yes. Yeah. It's where if someone show you a picture like this, okay, and you ask him you ask him which level you took the imaging. 1, 2, 3. 1, 2, 3. 2. There is no margins, right? It's 1. Upper third. If you move the probe to the middle third, there is a margin in here. Okay, so if someone show you a picture, you have to look at and tell you this is an example of tibia and tibialis. Tibia, interossei membrane, right? Cortical line is not clear. It's all right. It's a textbook of bad examples. and you know, you can judge it. Okay, cortical line is not clear. Muscle transsectional area is not clear. I didn't see any starry night. This is rubbish. So the book is very cheap. So you can free download. Okay, but you can look at something like this, and you know, okay, I can make my image better. Okay, thank you. Then high resolution ultrasound. This is central part, right? Central part of the leg. Bipanations. The angle are different. The superficial part is flat. The deep part is sharper. So, for the tibia and tibialis, which layer provide much more force to the others? The superficial part is much stronger, or the deep part is stronger? Yes. Yeah. So the people with training, the deep part is stronger because the penetration angle is bigger. So that would be different. Okay. So we need to be very careful. Without poor skill, you may lose the superficial part, or you may lose the deep part. So you have to use very correct angle to check the both superficial and deep part. Okay? You know how to get the right image by the 7th scale. If the muscle move and the border of tibia and tibialis away from the tibia, that's the herniation. And you can use 7th scale, the 7th scale, compress and make the attachment of the tibia and tibialis back to the tibia. When you move your probe or decrease the compression force between the skin and the probe, and you observe the detachment, the attachment happen again. That's a typical example of tibia and tibialis herniation. It's not rare injury. It's not rare injury. Athletes tell you when they lift their big toe, there is a bump in the leg. Okay, you will notice this is probably herniation of the tibia and tibialis. The size of the tibialis herniation will decide whether or not this patient is going to have a surgical repair. But surgical repair outcome does not always good. So compression, where a very tight garment is probably the one of the solution for temporal. Yes, yes. Especially for the football player. Okay. We also look at the extensor digitorum longus. Extensor digitorum longus and the tibia and tibialis tendons, they are all often suffered from tendinopathy, like this one, the fluid surrounding the tendon, and also the hypoechoic in the tendons. Okay, and sometimes longitudinal view. In the longitudinal view, we can find the fluid above and below the tendons. That's the tendinopathy. And if you observe any picture like this, please always put the power or the color on the tendon. So you check whether or not there are vascularities in this hypoechoic area. If there is, it is active inflammation. Okay, anti-inflammation or reduce the inflammation is the best, and so is the first priority treatment for the patients. Okay, so you look at the tendons and you notice there are some muscle fibers underneath. Good. That's the extensor hallucis longus. Typical pictures of extensor hallucis longus. There are a lot of free imaging in Google or in a lot of search engines. You just type the image that you need and look at them. They are free anytime, and as long as you pay for the internet. So, okay. But I can share you some secret. If you do not have internet, you still can access the Google. But I'm not going to tell that now. Cool. Okay. Again, we are going to move to peroneal longus, but you have to practice in the lunchtime. From the top, we find the fibula first. The neighbor of the extensor, the neighbor of the peroneal longus, okay, is the extensor digitorum longus. So extensor digitorum longus, extensor hallucis longus, tibia and dialis, right? 12, 1, 2, 3, 4. Okay. There is a superficial nerve between the peroneal longus and the extensor digitorum longus. It's called superficial peroneal nerve. Easy to get hidden by traffic, or sometimes, unfortunately, if the cast, people because of fracture they have to wear a cast. The cast is too tight, and the cast compress the superficial peroneal nerve. Sometimes, unfortunately, it happens. So, and the cast induce muscle sensation numbness, and okay, the cast probably compress the superficial peroneal nerve. Okay, the neighbor is the extensor digitorum longus, named peroneal longus. When you go down, the peroneal brevis appear. Okay, in the deep part. And when you move down, the peroneal longus tendons show up in here, close to the malleolus when you move down. Okay, and you can find the tendon of peroneal brevis appear and took the place of peroneal longus. That's the level we are going to practice later. Okay, but I'm going to finish my presentation before you practice. Soleus, medius, and Gatronianus. We did this in our first day class practice, right? Okay, so I'm not going to practice, but I want you to practice by the following instructions. When you look at the medial gastrocnemius and the medial and the lateral gastrocnemius at the knee level, it looks like sunglasses, right? That's my teacher said. It looks like sunglasses. And yesterday, it looks like Gucci, right? Yeah. Okay. Then, when you move down, you found that the volume of the gastrocnemius increase, but when you continually move down, it reduces very quickly, and you found a very big soleus underneath. Okay? I'm not going to show this, but you have to practice, because then turn 90 degrees, measure the angle. Again, just practice. That's the first day, the practice in first day. So you should be okay and no problem. You need to combine the first day, what you learned on first day, and the second days. Transverse views, second day, right? Move down, rotate 90 degrees, first day. And pennation angles. Right, This is the Gatornanians and the Solius. When a few years ago, a society is in UK, it's a Royal Society of Surgery, I think. It's a very, very high-rank society in UK. Well, one of the editors wrote to me, he said, is it possible to use one window to look at the penetration angle in the Gatornanians and the Solius at the same time? Because he get a paper submitted from a very top institute, and that institute report the angle change, the difference of the angle change, penetration angle change between the Gatornanian and the Solius. I said, he's a sir, yeah, dear sir, blah, blah, blah. According to my experiences, it is not possible because the alignment of the Gatornanians and the Solius is not parallel to each other. So there is no way to use one window to look at the penetration angle in the Gatornanians and the Solius at the same time. Okay, the editor replied me, say, thank you very much. And he is wondering why a high-rank institute make such mistake like this. So it looks like clear, but it's not clear. Okay, so if you want to measure the penetration angle in the Solius and Gatornanians, you need to do the sense test twice, at least twice. One for Gatornanians, one for Solius. Use the skill I told you about rotations, okay? Because they are aligned in different directions. Okay, calf muscle. When you lower in the probe to the end, you will find the Achilles tendons, transverse view, Solius. Then continue move to the Achilles tendons. Okay, now it's 15 past 11. I'm going to demonstrate the lateral side and the posterior side of the lower leg. Then we move to the medial side in the afternoon, and we introduce you the medial ankle and lateral ankle. They are totally more than 15 structures. Yeah, you understand, right? 5 ligaments. Okay, there are some work for you during your lunchtime. There's no free lunch, you know. I think you understand very well. Okay. Remember these 5 ligaments and 3 deltoid ligament. Okay, so we will practice in the afternoon. But now I'm going to show the skill about the lateral leg and the posterior leg. Then we have our lunch, and we have practice, and we have our lunch. Okay? Any questions? Okay. One more, Pontaris. Yeah, Achilles, because we are going to look at the Achilles. Why not look at the Pontaris as well? Okay, so let's do it. Basically, we use side lying position, okay? Basically, side lying. But because we don't have a bed, so just use these, yeah. my friend is a friend of mine. He's a physical therapy, and he's very good in mechanical engineering. I know Azan Puicha sounds mechanical engineering. So I told my colleague, can you make a device for me? Because my friend, he's a physical therapy, yeah, but he's not doing anything about physical therapy. Yeah. He designed. Do you know some? I'm not going to say the name of the car, but you know some very luxury car, you can use hand to give the instruction to the car, right? No. I'm not going to say it. Yeah, that's basically his idea. And there is a GPS for the car, right? So just and you don't need to touch the screen. Yeah, he's doing something like that. And I asked him, I need a pointer. The pointer pointed to where my eyes are looking at. And he said, do you know what he said? He said, Professor Wang, the problem is not where you are looking at. The problem is the stability of the head is not good as a hand. Even I'm looking at something, but my head is still moving. That's the problem. So if I put a pointer like in here, like very stupid guys, but even I look at some places, my head is still moving. And he say, the problem is not where you are looking at. The problem is the head, the stability. He's very smart, right? Very, very smart. And he's a physical therapy. I'm very proud. Yeah. Okay, cool. Because there are some jails. Yeah, so it's alright. It's a disposable. Right. We got the okay. Fibula head. Fibula head. Fibula head. Okay, that's the extensor digitorum longus. So I need to, the probe is wrong. See? But without this, with this, it's very easy, right? Yeah. Always check the orientation. Dun, 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 dun. Okay, fibula. Okay. Say goodbye to the extensor digitorum longus. But if you are still interested, there is a okay. The common peroneal nerve just passed by the head of the under the head of the fibula head. See? Right? The common peroneal, are going to separate. You can trace the nerve. See? It's moving deep. Okay, but today's job is the peroneal longus. A border, right? Extensor digitorum longus, peroneal longus. There's a border. Find the border, and find the muscle. Dun, 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 dun. Very big. Dun, dun. Okay. Find the deep muscle. Please. Longus tendons. Right? Longus tendons. Did I tell you the longest, the peroneal extensor digital longus, small superficial peroneal nerve, right? And this nerve is come with an artery, right? See the pumping. Okay. Go with the tendon. Dun, 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 dun. Right? Thank you. To here. Yeah. Thank you. Right, see the tendon, right? Tendon in the middle. Then, okay. Peroneal longus tendon. I love tibia very much. So I stay with you. Why? There is a brevis between us. Which one you like? You like me longus or you like him brevis? Longus, I always stay with you, tibia. Why there is a brevis appear between us? Right? Okay? The level. When the level is high, I mean the probe level is high, you can only observe peroneal longus tendons. Okay? When close to the lateral malleolus, the brevis tendons show and run between the longus and tibia bone. Okay? And the longus is ovary shape. Can you hold that for me? The ovary shape. The brevis is like a new moon. Hold. Okay, hold the longus. Yeah. And okay, I'm not. I need to ask a young guy. Okay, if you have a girlfriend, I think you have a girlfriend. Yes, sorry. If someone want to talk to your girlfriend, and you don't like him, and you think he got some purposes, what will you do? For attendant, yeah. So, yeah. Okay, okay. The way I think talk does not work. Yeah. Okay, you just find some talk and walk between the guy and your girlfriend, right? So he's not going to close with your girlfriend anymore. That's it. That's Dorsey fractions. Okay, because of the rotation, right? We test. Okay, good. Longus tendons, longus tendons. Okay. Yeah, don't do too much pentaflexion. Pentaflexion is going to make the peroneal longus and brevis more short. Okay, that will be a little bit difficult for the to observe. Right. Okay. Longus brevis, longus brevis, longus brevis, longus brevis, longus brevis. Okay. Okay. Then can you do the dorsiflexion slowly for us? Okay. More. Okay. Relax. Okay. And you can see the longus try to move forward to take the place of brevis. Brevis is moving backwards slightly, right? During the dorsiflexion. Do it slowly, yeah, not too forceful. Okay, do that again. Okay, and then relax. Okay. Okay, do that again. Okay, stop. Then backwards. Do that again. More. Slightly. Good. Brevis, move this way. Longus, move this way. Okay? If you cannot do it, it's okay. Just use the probe, follow the tibia. Find the relationship between longus and the brevis. And if you can, your hand is very steady. Ask him to do slow, gentle dorsiflexion. And it was like this, right? Then the peroneal and longus try to rotate to each other during the dorsiflections. Okay, so this is the best way to observe the the peroneal longus and the brevis interactions. Okay, let's do it again. Okay, no problem. So you like this one, right? Right? So rotate this one. Oh, sorry. Let's rotate. Then back to their positions. Back. Right? Right? Okay, can you hold me? It's like this one, then rotate. Okay? Right, you can see that? Can you? You can? Okay, yeah, okay. If you can understand, I think it should be okay. Because from your distance. Yeah. Okay. Rotate again, rotate. Rotate. Oh, sorry, the wrong directions. Right? It was like this. Now it's like this, right? The longus try to take his position back from brevis if you use dorsiflexion. This rotation is very, very important. And this interact movement is lost in foot ankle instability. Okay? This rotation or interaction is lost in ankle instability. Okay? Good. So, you have to lie down now. So, can we give him one more chair? Yeah. And you need to stand up. No. Because one more chair. Prone. Yeah. Good. Right. Sunglasses. It's like sunglasses to you? Sunglasses. right? It's not like Gucci. It's another brand. It's I know it is. Yeah. Yeah. Thank you. Right. Gucci is like this one, right? Yeah. Because my daughter, work in the Louis Vuitton. Yeah. So she bring a lot of sample. No, not really sample. It's a paper. Yeah, with pictures. Yeah. Okay, sunglasses. Good. Sunglasses, right? That's okay. Right, sunglasses. Okay, sunglasses. Anyone agree? Do not agree? Okay, sunglasses. Okay, good. So you are good student of my teacher. Good. Medial gastrocnemius. Move down. Dun. Soleus. Yeah. Thank you. Soleus underneath. Soleus is very big. Okay. Yeah, soleus. Soleus. Very big. Yeah. But if the angle is right, the soleus is very bright. Yeah. If the angle is right. Okay. Because the alignment of the medial gastrocnemius is oblique, right? So I cannot use horizontal way to hold my probe. It should be rotate. Okay, then pronation angle. Okay, for some papers, journal, they require to see the tibia bone as well. Okay, anyone want to do study with the gastrocnemius? Skin, fat, and the tibia bone. And this is the fat. But sometimes, if you see muscle fiber here, is flexor hallucis longus. Okay. Yeah, if your supervisor told you you are going to do study with the ultrasound to look at the muscle morphology in medial gastrocnemius, you can run away or tell him or her you are ready. The curve is like dun 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 dun. It's not straight. In the end, it's never straight. Never straight. Never. The muscle dun 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 curve. You have to show at least one of the insertion to please the editor. If you want to publish, please plug in the PowerPoint. Okay. Yeah, thank you very much. Thank you. Thank you. Skin, fat, superficial aponeurosis, physical, deep aponeurosis. All of them need to be perfect for clinical services and research. Okay. Go, 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 go. Right. This is, ladies and gentlemen, this is the end of the medial gastrocnemius. Can you please press the freeze? Thank you. The end of the medial gastrocnemius. The beginning of the Achilles tendon superficial layer. Okay? Dun, 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 dun. The end of the medial gastrocnemius, the superficial layer of the Achilles tendon, dun, 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 very thin, it's very thin. And when you look at the beginning of the Achilles tendon, you think, wow, it looks like it's fingers tendons, very thin, very small, right? It looks like tibia dialis. Sorry, it's my fault. Extensor hallucis longus. Yeah, very thin, but in the close to the end, oh come on, wow, become very thick, right? Okay, if you look at the transverse view, no, it's very small, not at all. Dun 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 dun. Wow. The Achilles tendons, very strong. This area, sorry. This is the fat, right? This is the Achilles tendons. Sorry. This is the Achilles tendons, this one. Okay, this is the medial side. This is the lateral side. This is his Achilles. I'll try to make it bright. It's not stand-up positions. Okay, basically, right? Okay, so bend your knee. Yes. Dorsiflexion is very important. Can you fix her? Yeah. Dorsiflexion is very important to see the Achilles tendon. Right. This is very bright, right? Okay. Thank you. Okay. Longitudinal view. Longitudinal view. Can you use the pointer for me? Yeah. Okay, if I use floating scale, Pimongkong, you need to help me to hold his foot. Yes, thank you. Floating scale, heel lifting scale. A lot of scale. Freeze. Dun, 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 dun. Okay, I did my best. 2 layer structures. Yes. Ooh. Superficial layer. Deep layer. Deep layer from soleus. Superficial layer from gastrocnemius. Okay. You are very good. Azan Puja. Yes. Yeah. Sorry. Okay. Dun, dun, dun. Oh, sorry. Medial side. Achilles tendons, very bright. No, now we go to the end of lucky sentence. That will be more easier. Yeah, very bright. Okay, so another another skill that never existed before. You put the gel in two ends, just two ends. Medial side, lateral side, yes. This is super floating skill. Okay. There's a lot of gel. Yeah, thank you. Thank you. Thank you very much. Okay, my question is, when you are measuring, when you stretching the Achilles tendon, and then you want to change the diameter, the width change, right? So you, option one, you calculate from here, from here to here. Which one? Option one. The width is between this point, or this point, or between this point and this point. Which one? Are you going to measure from here to here? Okay. Here to here. Second, here to here. No? Good. First one. Good. Wrong. Pontaris. This is Pontaris. Slight different, right? The color, the brightness is slight different, right? Slight different. Yeah. Most people, the paper I read published in a country above Taiwan. Yeah, they have very famous sakura. The report slightly away from my expectations because they include the Pontaris. Actually, this is the Pontaris, ovary shape. So this is the Achilles tendon. Yeah, this is Pontaris. Yeah, Pontaris is stronger than Achilles. Okay, so if I am just one, thank you very much. Yeah, good. So when I look at the Pontaris, the color is slightly different. Yeah, thank you. So I put the Pontaris in the middle of the window, then turn 90 degrees. Very super strong. So if you follow it, you find a very bright spot in here. Yeah. The cross-sectional view of the Pontaris tendons, very bright, between the soleus and the gastrocnemius. And you turn 90 degrees. Okay, freeze. If you find a very bright tendon-like structure below the medial gastrocnemius, end of the medial gastrocnemius, and the soleus, Pontaris. Yeah, Pontaris. Plantaris. plantaris. Yes, thank you very much. Good, it's your job. Practice until 12:30. Then we have a lunch to 1:30. Then we have 3 hours left. Yes, 3 hours left for an ankle. Then pack. Muscle and tendon before the lunchtime. And we can ask the patient to do the dorsiflexion. If you observe there is a gap produced between the skin and the longus during the dorsiflexion, or dorsiflexion and the eversion, you may suspect the herniation of the peroneal longus. And if you ask your patient to do the dorsiflexion, and you found that the tendon climb over the lateral malleus, this is a case of peroneus tendon dislocations. Okay? Someone get hit. The pointer. Oh yeah, thank you. And there are a lot of swelling in here. You would like to check whether or not there is a bone contusions. Okay, this is an example of fracture callus. Callus is very bright, slightly echoic shadow. Callus strong, hypoechoic and thickening periosteum, right? Color to check, no blood. It's okay, stable, weight bearing, carry on. Colors, not stable. Okay? Partial weight bearing exercise, maybe with Theraband. Okay? No fracture sign. Focal thickening of the periosteum. Shin pain or compartment syndrome. Shin pain most likely. Or periosteocytis. Periosteal membrane inflammation. Okay. Acute compartment syndrome. The focal area is very bright. Like there are a lot of small white dots in the involved area. It should be like starry line, right? It becomes very bright because there are a lot of micro tear or the fluid filled in this area, so it's become very bright. Gastrocnemius, soleus, flexor hallucis longus maybe, and this imaging combine a lot of views. So if you are using a textbook with this imaging, it's very, very difficult for you to learn because most of us do not have an ultrasound with a panoramic view. Okay? If there is a focal swelling here, and in this area, you can see the continuity of the physical fibers. It may indicate a muscle ruptures in here. Okay, and this you also can make a bilateral comparison. I often do this if I find the abnormal morphology in a unilateral pen patient. Okay. This is another example. The left soleus has a muscle tear corresponding to the longitudinal view. And MRI also proved this muscle tear observed in the ultrasound. Okay, we are going to skip this one. Okay. When I mentioned in the morning, when we close to lateral malleolus, the peroneus brevis take the places of the longus, and peroneal longus is round shape, and the brevis like new moon. And during the dorsiflections, the longus rotate clockwise, okay, and move anteriorly. So, if someone show you an imaging of peroneal longus and the brevis with the moon's shape, new moon shape of brevis, you know this ultrasound imaging is taken very close to malleolus level. Okay? If no brevis can be observed, the ultrasound imaging probably taken above the malleolus level. Okay. Basically, it looks like this. Brevis close to the malleolus longus. But during the dorsiflections, the brevis, the longus, move forward and close to lateral malleolus. The brevis move backwards. So it's a clockwise rotation. Clockwise rotation. Remember, people who has the ankle instability, these clockwise movement may disappear or may different to the normal. But very few research report this parameter can be is related to the symptom or not. But this is very interesting because we know the position of the tendon is very important to muscle to transmit the force to the insertion site. Okay, we are going to use the time before practice to introduce 3 parts of the foot and ankle. The first one is tarsal tunnel. We are going to put our probe one end on the medial malleolus, the other end to the insertion of the Achilles tendons. Insertion of the Achilles tendons. So we will see the tibia posterior, very bright. Another bright area close to tibia posterior is flexor digitorum tendon and nerve, artery, vein, and a very bright nerve. Then a tendon below to the nerve. That's tibia posterior, flexor digitorum tendon, and the flexor hallucis tendons. Okay, so tibia posterior, flexor digitorum, artery, nerve, and flexor hallucis tendons. Okay. Then if okay, then we are going to introduce the ligament in the lateral ankle. We will start from ATFL, anterior talofibular ligament, then CF, then PTFL, posterior talofibular ligament. Then we go to posterior tibial fibular ligament. This is quite difficult. This is quite difficult, but these rests are very easy. Okay, then we move to the deltoid ligament. We look at the posterior bundle of the tibia talar ligament and the tibia calcaneal ligament and anterior bundle of the tibia talar ligament. Okay, that's the structure we are going to practice in this afternoon. I will start from the tarsal tunnel. Okay. Okay, strong guy, come on. Take over yours. Yeah, thank you. Do you want to put your... They are making things easy for them. Okay. Right. Okay. Okay. And external tissue. Yes. Okay. And the slightly eversion. Slightly there. Okay. Okay. So we need to change to okay, cool. Good. Oh, it's almost empty. Good. Very Very easy. Find the medial malleolus. Insertion of the Achilles tendon, right? Thank you. Medial malleolus. Insertion of the Achilles tendons. Probe. Freeze. Tibia posterior. Flexor digitorum tendon. Artery, nerve. Flexor hallucis. But it's stuck because of the angle. Because of the angle. Okay. Once more. Medial malleolus. Ear. The top of the calcaneus. Okay, freeze. Tibia and tibia posterior. Flexor digitorum. Artery, vein, nerve. Somewhere in here. No, because the window is not wide enough. But it's okay. No problem, right? Tibia posterior. Flexor digitorum tendon. This is very bright. This is not tendon. Okay, because the artery is here. Flexor hallucis longus. Flexor hallucis longus. Okay. Can you sit backwards a little bit? No, backwards. Yeah. Okay, thank you. So why I'm sure this is the flexor hallucis tendons. Can you? Yeah, good. Okay, relaxed. Okay, we need to. Okay. Do it again. Okay, thank you very much. Is it here, right? Do it again. Okay, thank you. More. More. Artery, nerve, flexor hallucis longus. Flexor hallucis tendons. Good? No problem, right? No question, right? Good. You are totally confused, right? That's my purposes. No question, and the class is finished. I will do that once more. 5 seconds job. I think he learned a lot because he watched every detailed movement I did. Find the medial, cell practice. You Hold the probe. Yeah, look at your tibia posterior. I know you have very good mobility in the back. I will be your assistant. Good. Medial collateral ligament. Medial malleolus. Tibia posterior. The flexor digitorum is not clear, right? Come on. You can do better. Good. Good. You are very talented. But just for the tibia posterior. Okay. Tibia posterior. Flexor digitorum. If he can do this, no one can do. Everyone can do this. Because sorry. Because he is doing by himself. Okay. Okay. Find the tibia posterior, right? Find the flexor digitorum tendons. Move to the artery. Then this is nerve. Flexor hallucis tendon is waiting for you here. So, okay, don't move. Your first girlfriend, second girlfriend, third boyfriend. Girlfriend. Sorry. This is the last girlfriend you are going to look for. Move. Sorry, I was a little bit tired. Yeah. Good. Your first girlfriend, second girlfriend. Yes, third girlfriend. Because this is very bright. Because this is artery. Good. I didn't expect this is so easy. I know it's easy, but it's so easy. Okay, good. That's the artery. That's the nerve. The flexor hallucis tendon is here. Okay, I will take your hands. Then you carry out the flexor. Right? Tibia posterior, flexor digitorum, nerve, artery, nerve. Then you need using tilting. Look. Okay. Okay, sorry. Big toe. Good. Your last girlfriend. Maybe you have one more. Oh, you are smiling. Good, very good. You don't want to have one more, right? Okay, good. Right. Then another leg. Easy, right? He just look at me and show 3 times, and he can do that by himself. Easy. Okay. A little bit side lying. Ooh, good. I don't want to break another mic. Yeah, thank you. So, is your girlfriend a physical therapy as well? Okay. I mean, no, then. So I'm too bad. Okay. Okay. In the old time, when I was a student, the standard positioning for ATFL is long sitting, bend knee. Okay, now a couple of us, we change it to this position. We think it's better. So more easier. So if you look at someone using long sitting position and with a bend knee, it's old generation style. Okay, young generation use this kind of. Okay, easy. Palpate the fibula head along to the lateral malleolus. Okay, it's slightly pent up flexion. slightly pentaflexion, slightly inversion, right? In this side position, right? Sideline positions. One end of the probe, the other end toward to fifth toe over little toe, small toe, little toe, fourth little. Okay. Some floating scale. Wow. That's too easy. So I should retire. Ooh. Can you press the slide for me? Yeah. Move to down. Move. Continue. Go. We want to go home. Come on. Yeah. Go. Backwards, not forward. Yeah. Hit to the 50. Yeah, I think. The number is 50. 60. Okay, thank you very much. 60. 60, yeah, yes, good. This one? Okay. ATFL. I try to make the ligament much more brighter than like this 3 million bar device. I try my best. Okay, easy. Lateral malleolus, right? Side lying, slightly dorsif, not slightly penta, just slightly penta. And the eversion, yeah, slightly inversion. Proximal side, distal side, proximal side, distal side to the fifth toe. Okay. Ooh. Easy, don't worry. Slightly brighter, right? Slightly brighter. ATFL. Okay, one more. And I'm going to move to another. Lateral malleolus. Fourth toe. Slightly dorsiflexed, pentaflexed. Oh. Okay, freeze. Good. Fiber, 3 million bar, 30,000 bar. Good. One line costs you 50,000 bar. If you want more lines, buy that one. If you want to practice, This is okay, I think. You're right? ATFL fiber. Can you see that? Right? Okay. Another AITFL is anterior tibial fibular ligament. Okay, AITFL, right? Same positions. Move using the sliding walking scale. Okay. I plan to say freeze, but I think am I talking to myself? Okay. Next slide. Yeah. Okay. Okay. We are brighter, but the brightness can be reduced easily. Good. Fibers, right? It's easy. Okay. Yeah. No, anterior. Yeah. 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 You scare me. It's posterior. What's wrong with the foot? Okay. CF, calcaneal fibular ligament. Okay. In this position, side lying. Okay. This is the fibula. Very good tattoo. Fibula. Okay. Slightly dorsy, right? Slightly penta. Yeah. Straight. Slightly. Yeah, thank you. So we are thinking about the same scale, so you know what I mean. What do I need? Yes. Okay. Then, slightly posterior. Then freeze. Okay. CF is very close to the bone. Next. Next. The AITFL, we already show you. Okay, next. This is injury. Next. Oh, no CF. All right, okay. Yeah, very close to the bone. Is in the B. Look at the B. It's very close to the bone. It's the blindness one. Okay, this one. But I don't think. All right, because this is the the old generation. Oh, so first generation, not old generation. Yeah, this is the pictures of the first generations. Okay, so in the new generation, this one is very bright. Don't worry, you won't miss it. Okay, then PDFL. Same position. Lateral malleolus. Okay, I should save this one. Okay. CF. PTFL. Find the lateral malleolus and the calcaneus. Okay? The calcaneus. The top of the calcaneus is for tibia posterior. Okay? The calcaneus is for the PTFL. Okay. The ligament is very bright. Okay. The CF is very close to the bone. The ADFL and the PDFL, no, away from the bone, right? PITFL, easy. No, not easy. This is a little bit difficult. Probably a little bit difficult. Yeah. You're unhappy about. I said it's a little bit difficult. I think it's very difficult. No. I show you. Okay, the same position, basically side lying. That's why we modify the procedure. Okay, and then we inform our teacher. We probably use the same idea, but slightly different to what you suggested 20 years ago. And we changed the position from long sitting to side lying. And my students tell me that's it. It's easy, right? You find the lateral. No, I will do that again. You find the lateral malleolus. Did you remember you used the calcaneus for the PTFL? Use the top of the calcaneus for the and above the level to just the other end is about the middle of the Achilles. Good, easy. Easy. Very bright, right? No problem at all. 5 ligaments. And then last three. You want to practice now, or let me finish over then? You want to practice now? Okay, last 3. You give up. I will do it again. No worry. You do that for us. Right, because no, it's not difficult. No. Honestly, believe me, I did this before when I was This is possible. One, good. He's very brave, very confident. Which one you want? Good. Yeah. This is fibula, right? This is fibula, right? This is peroneal, long brevis and longus. Okay. Hold this for me. Let's have some game, some fun. Which one is longus? Which one is brevis? Now it's above the malleolus level, right? Above. Yeah. Longus is the front, brevis is the back. Close to the malleolus, the longus, the brevis become new moon shape. Yeah, this is longus. When close to the malleolus, it becomes this. Okay, good. Then when you find the longus and brevis, you know you are very close to PIFL. Yes, thank you very much. Good. Right. Dun, 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 dun. Dun, 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 dun. Good. So bright. No difficult at all, right? Okay. Which one you want? Next. Dun, 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 dun. Dun. Okay. Super floating. Yeah. Hold it. It's not. It's okay. Yeah, I'm not aging at all, right? PDFL. Okay, what do you want next? CF, ATFL, AITFL? Okay, all of them, I know. Okay, in 5 seconds, right? Okay. Okay, CF. Okay, CF. ADFL, right? ADFL, bright, like 3 million bar. Finish. AITFL. Thank you very much. Next one. Next 3. Deltoid ligament. Right, good. Right, okay. The same, very, very useful. From the tibia, long axis of the tibia. And find the tala. Yeah, thank you very much. I have some problem in pronunciating that structure. You can use that with palpation. Okay, that's the middle bundle of the deltoid ligament. Easy, piece of cake. Medial malleolus. And find the tali. Good. 1 directions. Put it down. Find the medial malleolus in the left side. Find the tali in the right side. Nothing. Both of them need to be shown. Okay, freeze for me. Thank you very much. Freeze. Okay. Malleolus, tali. This is the ligament. Okay. Because the deltoid ligament is diverse, only a few bundles can be seen by ultrasound. For example, if the deltoid ligament like this, if I'm looking for the middle bundle, there are some bundles beside the middle bundles can create shadow. But we can see one bundle very clearly. That's the middle bundle. Okay, again. Thank you very much. Medial malleolus. Calcaneus. All right. Sorry. one more about the middle bundle. Can you freeze for me? Thank you very much. There's like a valley. Okay, there's a gap in here. If you saw the ligament with too close bone mark, that is not middle bundle, because there is a huge gap between the tibia, talus, calcaneus, right? This is the structure of the calcaneus, right? So be careful of this profile. You need to show the profile in here, so you are sure this is the middle bundle, okay? Medial malleolus, calcaneus. Yeah, use medial malleolus, calcaneus, heel. Use the heel lifting scale. The distal is correct. The proximal is incorrect. Why? Why? Did you have severe medial ankle injury before? Did you? No, okay. You may find the shape of the medial malleolus is not very good, right? Okay. Okay, so I check this left leg, right, for the tibia posterior, right? If we move to see? Yeah, thank you. Oh, sorry. Okay. Oh, it's okay in this view. It's okay in this view, but there are small gap in the okay. Right. Find the tibia posterior. Then it is very close to the posterior bundle. Okay, so in his case, oh, sorry. Straight your neck, yeah. Dorsiflexion. Yeah, change the alignment. Yeah, thank you very much. Yeah, thank you. It's become very easy. Okay, freeze. Okay, the posterior bundle. over the tibial, talo, tibial. Yes, thank you. Oh, you're very good. So you can observe the fibers in this area, right? Right? Good. But we can see much better from here, right? Okay, that's the, now, last one. Medial malleolus, navicular bone. Okay, thank you. Then, here, can I have some more? Oh, no, it's all right. Use the heel lifting scale. Good. Then distal side. Cool. Freeze. So it takes a while to find because the medial malleolus is quite big. I stayed in here, but I found it's in here. The original of the anterior bund is here. So you probably need to use the heel walking around the medial malleolus to find the anterior bundle. Okay, no, it's all right. Okay, do it again. Thank you. Okay, freeze. Okay, you can see the bundle here, right? It's the anterior bundle of the deltoid ligament. So try, sorry if you do not mind. I'm going to do some pen drawing on his foot so people can practice. Thank you, marker pen. Okay. Thank you. Right. For the medial malleolus, straight his knee. Good. Yes. Thank you. Okay, cool. Right. Yes, thank you. Near slightly pentadorsiflexion. Find the tar line. Sorry, it's here. This is wrong. Find the tar line. Middle bundles. Okay. Anterior border. right? This one. Can you feel that? Yeah. Anterior bundles to the navicular bone. But the direction to the navicular bone, but it's a ligament between the talus and the tibia, and posterior bundle to the heel. Right? Okay. Feel that, right? This one. This one is very strong. Right? Okay. And then side line. Okay. Slightly there. Pretend you are side line. Okay. Good. Cool. Do you think about that? Do you consider to make some tattoo about anatomy next time? Okay, side line. Yeah, straight. Toe to the right. Right. ATFL. Okay. Slightly those. Yeah. 2. Slide. CF. Okay. PTFL. Okay. Slide walking. This one, very strong, right? AITF. This one, here. Right, this is the peroneal tendons, right? This one's here. Good. So basically, I think you need to stay here and do not move. Not leg. Right. Tibia posterior, right? Achilles tendon, right? Tibia posterior, extensor digitorum, artery, nerve, flexor, hallucis tendons, right? Okay, 1, 2, 3, 4. 1, 2, 3, 4. Yes. 5, 6, 7, 8, 9, 10, 11, 12. Okay, thank you very much. Anyone have any questions? Make a picture on his feet first. Good. We practice until can someone help me to get the participants outside in the room? Okay. Thanks for the Adan Wicha. He is a friend willing to share his image with us. So I will discuss this image with you after I finish my slides. Okay. Okay. We understand the importance of the structures, and we can use the imaging to evaluate the morphology of the ligament. And the morphology of ligament are very important to the function of the ligament. So sometimes the ligament tear with sprain or avulsion fractures, and most of them occur in the ATFL. 20% about 10 CF, calcaneal fibular ligament. And some articles or textbook suggest it is rare in the PTFL. So we often check ATFL first. Okay, but if the patient shows very obvious subcutaneous hematoma, I would suggest you to check the AITFL as well. Okay, healthy ATFL. I think this is no problem at all for you now. Honestly, it is not possible to become familiar with ultrasound in 3 days. Not possible. But you can become very interested in ultrasound imaging in 3 days. So, some people suggest we have some more classes, but that depends on support from Mahidol University. Yeah. They are laughing, yeah, I know. Right. If you cannot see the ATFL completely, it's very highly likely complete tear or almost complete tear. If you see the fluid around the ATFL, and still some still fiber can be observed, probably this grade 1 is minor. Okay, if you see the cortical change and also the fiber change, texture change, you may suggest it's osteo effusion or bone lesions, because sometimes the ankle sprain combine bone lesions. And the last one, you might see complete tear and effusions. There are some knowledge and skill about the joint effusion. I did not have time to explain today, but maybe next time. Okay, long axis, hypoechoic disruptions. It's a ligament tear. The inversion stress test also help to identify a injured tendon. But for me, as I said in my class, I often use color Doppler or power Doppler to check. Right, AITFL, healthy one. But there is, this is AITFL in MRI and in sonar. It's very, it's quite normal, okay? Fiber can be observed. This one is not normal, okay? The fiber cannot be observed. The morphology becomes thicker. There are some inhomogeneous signals inside. So that means a severe ankle sprain. And we probably need to check the syndesmosis as well. Okay, this is CF. It's very bright ligament, very bright. Okay, so should be able to see in the ultrasound, and you can use different posture to make the ligament more visible. But you need a very good machine because this tiny and the superficial ligament is not easy to look at with the, without a high resolution ultrasound. Right, in these figures, the peroneal brevis become round, the peroneal longus become moon shaped. That means you are close, or you are below the level of the malleolus. At the malleolus level, the brevis is new moon shape. Longus is ovary. Okay, so you know the interaction between the longus and the brevis is very interesting, but not a lot of research discussed about this. Right. And if you found the details in the brevis changed, okay, and there are some fluid around the tendons, that means tendinopathy or tendon tear. I do not often make diagnosis unless it is too obvious. Okay, this is a good example. A tendon trauma, they checked with color Doppler and found that this is the peroneus longus tendon tear, and also confirmed by X-ray. Medium ankle, we often check tibia posterior, flexor digitorum tendons, flexor hallucis tendons, and also the tarsal tunnel, and also the nerve. But I didn't mention any skill about nerve observation in ultrasound because it belongs to level 2. So, but find the medial malleolus toward to the calcaneus. You can find the posterior bundle of the deltoid. And find the calcaneus sustentaculum tali gap, right? And this is the middle bundle of the deltoid ligament. Find the anterior border of the medial malleolus toward to navicular. So you find the talus navicular in here, and this is the anterior bundle of the deltoid ligament tendon. Okay, so okay, if you suspect your patient have a tibial navicular ligament injury, so you need to find the tibia, talus, navicular bone. This is the tibial navicular ligament injury. Ligament. If there is a hypoechoic injury, it may suspect relate to an ankle sprain. And now this become a routine check structures in case of ankle sprain at the NTU hospital. Because we think, or we believe, or we found the prevalence of the tibial navicular ligament injury is very high in the case of ankle sprain. Okay? Tarsal tunnel, you don't have any problem in this, right? Tibia posterior, flexor digitorum, longus, tendons, flexor hallucis longus, tendons, and nerve, vessel, nerve, no problem at all. Okay, we are going to I think there are some examples of the tibia and Achilles tendon tendinopathy can be found in the internet. This is an example of Pontaris injury. You can see in the transverse view, you can find there are fluid in the ovary shape or round shape of the Pontaris, and they are color duplas in the case of the Pontaris tear. Okay, before I told you, you are very welcome to go home. I think there are some pictures you may want to have a look. Okay. Good. Right. I tell you what you found in this imaging. This is the imaging of ATFL. Is it good? ATFL. ATFL is here. Okay, the case about I think it's more than 50, right? Under 60. Had an ankle sprain before. Then he has residue of pain in the ankle and the foot. And he came for help. This is, it does not look like very good. There is a hypoechoic in this area. It looks like a scar, but color dupla show nothing. Okay, maybe healed, but it's not very good, but it's not good looking. It's all right. Next one. CF. Do you like this fish CF? He has an injury in this ligament as well. If you check, okay, who is the youngest guy in this room? He? You? You, right? You are the youngest, right? You are the youngest. So who is the youngest? We're probably the second youngest, yeah. Who is the youngest guy? Okay, cool. What is the function of the tibial navicular ligament. When we doing the dorsiflexion, the big toe is doing the extensions. We are going to have a function like this. It's called windlass, right? The ligament is responsible for the windlass ligament, mechanism in the dorsal side. Ankle sprain sometimes leads to the ankle sprain sometimes lead to the tibial navicular ligament sprain. Okay, in this case, the patient every time use the windlass ligament mechanism going to hurt. So I would suggest that I would assume he has problem when walking, right? Standing. Yeah, but walking. Okay. So now the skill and the knowledge that I told you may help this patient to differentiate the location of injuries. So may help us to develop our treatment strategy. So 5 more minutes, then we finish the discussion and ask you, do you have? Basically, the plate, screw, only cover certain range of the fracture site. You can find the space to look at. Easy, very easy. For example, in this case, the plot, the screw, you can look at it from this side. You can find the space, no problem at all. Yeah, a case of mine, he was referred by my colleague. He's an orthopedic doctor. And the patient had a surgery for clavicle fractures. And it's non-union. So the case had a second operation at NTU hospital. And we use ultrasound to look at the fracture sign. The gap is very big. And he was told he's a risk. He's at a high risk of non-union again. And the better way for him probably is make a pin, put a pin in the clavicle. And he asked me my opinion. I say, okay, according to my experiences, if you put a pin in the clavicle, you are eventually going to have a foreign shoulder. So do you want to have a foreign shoulder? And he said, no, I don't want. And I said, no, okay, let's do something like this. I and my colleague were crazy guys. So we change the fracture sign. How? We cut a little part clavicle bone from other healthy side, make the powder, and put it in the gap. Yes. And it works. It works. By looking at the ultrasound, we found the colors formation very quickly. Yeah. But he is a nice guy. And he told me, my recovery is very good, but just one thing. I said, okay, what? He said, when he take off, his wife say, the shape of the acromion is gone. I said, okay, don't worry, your wife does not mind your acromion shape is gone. Because we took it out and make it powder and put it into the gap. Yeah. So in that case, we use ultrasound to look at the colors formation to ensure the operation is success or not. If it is, we carry on our treatment. If not, the patient has not to be wait for a long time for a poor outcome. He knows the result a little bit early, so he can decide what is his next step to do. Okay, and there are a lot of hole over the plate and the screw in the previous operations. So, but we don't mind at all. We just find the colors and check the blood flow in the colors. That is a very success case in our clinic. Yeah, just take a little bit. So his the involved shoulder looks like very flat, and he said looks like lady's shoulder. I said no, I don't mind at all. As long as your wife does not mind, it's okay. Yeah, because you know what I mean, right? Just it's a very flat. Yeah. Okay, colors, good. Yeah, different. I said in my slides, the power is more sensitivity than the color. The power is looking for moving blood cell. The color is looking for blood flow. Yes. If you are looking at the minor change of the vascularity, you should use power. Yes. In the case I show you, I use color because it's so obvious. Yeah. 2 minutes. Thank you very much. Thank you. I'm looking for next time. Yeah. Okay, thank you very much. Thank you very much.
ขอเวลาสักครู่นะครับครับก็เป็นการจับจุมครั้งแรกของประเทศไทยเกี่ยวกับเรื่องของอุลตราซาวด์อิเมจิงนะฮะของสำหรับนักกายภาพบำบัดนะครับก็ต้องขอบคุณอะไรคือทางโปรเฟสเซอร์นะครับก็ please thank you very much for help
rotation
all thank you very much ครับแล้วก็วิทยากรผู้ช่วยนะอาจารย์จากมหิดลนะครับที่มาช่วยให้พวกเราได้มีความรู้เข้าใจนะครับสมาคมนะครับในการที่จะจัดอบรมให้ประโยชน์นะครับรบกวนทุกท่านเสียเวลาสัก3 นาทีนะครับเข้า QR code เนี่ยฮะประเมินความพึงพอใจนะฮะในการใช้บริการการอบรมครั้งนี้แล้วก็ถ้าข้อเสนอแนะคอมเมนต์ได้เลยนะว่าอยากให้จัดเรื่องอะไรเกี่ยวกับเนื้อหาลึกหรือเรื่องอะไรบ้างเกี่ยวกับทางด้านอุลตราซาวด์อิเมจิงนะครับช่วยคอมเมนต์นิดหนึ่งครับแล้วก็ขอทุกคนเดินทางปลอดภัยนะครับขอบคุณครับ